introduce you and then, okay. And with that, so we are pleased to have Gene Cavallo here to discuss our largest behavioral health hospital in Arizona, Valleywise, formerly known as Maricopa Medical Center. We've asked him to talk about just evaluation beds, the demand for evaluation beds, kind of number of inpatient beds, typical length of stay, number of people that get put onto COT after the evaluation, that's cold order treatment, the impact of COVID when it began, and if it's still impacting any of their um, bed capacity or availability or staffing. Now, Gene Cavallo is the Senior Vice President of Behavioral Health Services for Valleywise, which operates the 126 bed at Desert Vista Behavioral Health Center in Mesa, the 93 bed health center in Phoenix, and the 192 bed behavioral health center in Maryville, and numerous outpatient behavioral health programs. He's a member of the Behavioral Health Constituency Group of Arizona and Healthcare Association. He's a native of Phoenix with more than 35 years of his professional career in behavioral health here in Arizona. And prior to the nearly 19 years in his current position, he worked in a variety of direct care and administrative capacities at both the provider and payer levels since 1987. So Gene has been around. You don't look that old, so, but
Yeah,
your experience.
60 next year.
Oh my gosh. So Gene's a licensed professional counselor, holds a degree from the University of Notre Dame and ASU. Go Devils. So with that, Gene, if you'd like to begin, and I just want to remind everyone, Gene's providing kind of general information, not one particular case, not one family member that needed a bed and couldn't have a bed. So it's kind of general information and general topics, not your loved one's individual situation at some point in time. And with that, it's over to you. And do you prefer people ask you questions during the talk or after the talk, or how do you prefer
Yeah, I
to
was
run
just
it?
going to ask you. I don't have a preference. Sometimes it's easy just to do it as we're going, since it's not that many folks, but I guess we
Okay.
can kind of see how it goes. Um, yeah, so thank you for the introduction. I think everybody realizes that normally you would have Dr. Carol Olson do this, but she's enjoying some well-deserved vacation. And she said, given the topics, I could address them, almost as well as she could. So that's why I'm here. So let's try and see if this sharing screen thing works. Did you
Yes, we
see?
can see.
So
Mhm.
one thing, I'm not one of those people that loves to create slides and have the most possible slides. I just use them as a little bit of a guide to what I'm going to say out loud. So I also believe in not recreating the wheel. So we are a public health system. I think you all realize the Maricopa County Special Healthcare District, and we have an elected board and we have public meetings. And I give regular presentations to our district board at the public meetings. And just so happens in the month of August, I presented some slides, and several of them fit really well with this, what you wanted to know. So this particular slide comes right from last month's meeting. It just sort of outlines what we're doing with our beds. So let me just quickly run through that, and then we'll see if we have any questions. So we have 412 licensed beds for inpatient psychiatric hospital care under Valleywise Health. We are currently operating 355 of those, which is 86% of the beds that are licensed are actually open. then I broke it down into the 3 locations. The Desert Vista is fully open and had been throughout the pandemic. We never closed a single unit there. There are 5 adult units with 112 beds and 1 adolescent unit with 14 beds. At the Annex, also known as our Behavioral Health Center in Phoenix, we have 93 beds, 4 separate units, all are open. There were closures beginning just before the pandemic, which was part of our bond spending. We had intended to close 1 unit at a time at the Annex, renovate and reopen. And then COVID hit and it kind of changed our plans a bit. But we did get through all of those units. So even though it's our oldest facility, it has been renovated in the last 4 or 5 years. And then Maryvale, we have a total of 192 beds. Only 135 are open as we speak. The exciting news here at the very bottom bullet is beginning of October, we will open 1 more unit with 15 beds. And then ultimately, as we hire more staff, we can increase that beyond. So we went, let's see if there's any questions about this slide before I go to the next one.
I assume, Gene, hi, it's Rachel. I assume you're gonna explain why not all beds.
I will.
Okay.
So, excuse me, this is Barb Honenberg. So the 15 more beds that'll be added, is that part of the 2 closed units currently? Or is that a unit, a
All the
third unit?
words. Is it? You said the 15 beds, is it? And then I think you cut out, at least I didn't hear that.
No, sorry. So there's 2 adult units remain closed,
Correct.
48 beds. Next step, you said, will be to open another unit at reduced capacity. That's 3 adult units from that part.
What the Maryville units are all 24 beds. What we did back in February, we opened all of the rooms. There are 15 rooms with 1 patient each. It allowed us to get those open with fewer staff, but the single rooms really helped us in our overall capacity management, because at Desert Vista in Mesa and at the Annex on the main hospital campus, we don't have any single rooms. And so when we have someone who either for a temporary or their whole stay can't have a roommate, it lowers our total capacity. So opening up single rooms at Maryvale has really helped us a lot when we did it in February. And so we're going to do it here again in October. And I'm not yet to the point where I can tell you when we're going to do the last unit. I'm guessing May or June at this point. We will have all of the units open, but those single rooms really give us a lot of flexibility. And then we'll go back and backfill them. The answer is staff, is why we've not been able to get them all open, but we've made significant progress. We have really focused over this last 2 years as an organization on the pay rates for our behavioral health inpatient technicians and our behavioral health inpatient nurses, and have made significant inroads in our pay and therefore our ability to recruit and retain. So it's been a difficult time, as you can imagine, for hospitals, because the demand for staff continues to increase. The ability to compete with other hospitals gets more challenging when many of them can pay a lot higher wages than we have been able to. But it feels like we've really turned the corner. We had a number of interviewing and hiring events in the months of July and August, and we really have brought our vacancy rates from high double digits, like 50 or 60 nurses and 70 or 80 behavioral health techs, down to single digit numbers, 5, 6 people. So we really are much more confident that we're going to be able to deliver this entire 412 beds to the community before, 18 months is kind of what I'm projecting right now.
Thank you.
So let's just talk about, I sometimes joke around with our staff that they've all become very good air traffic controllers, and those skills could probably translate to that profession. But we do a lot of work continually throughout the day to make sure that when we know we've got someone discharging this afternoon, we've got somebody lined up to come in for admission, and just not allow too many beds to go unused at any given time. So not only have we opened more beds, but we've maximized the beds that we do have. And this next slide, oops, trying to use my ruler, really kind of shows you over a 3-year period kind of what we have done. And as you can see, it breaks it down into the fiscal year ending June of 2022, 2023, and 2024 is what's on the left side of the screen. And then on the right side is the month of July. I don't yet have the month of August numbers. I'll tell you a little bit about August in a minute. We saw a lot more COVID in August, which is sort of complicated our lives a bit, but that's just kind of how it's been going. So you see our admissions, 4,172, dropped a bit the next year, and then a big increase the year that just ended. And then you see our average census, again, 270 up to nearly 300. And then in the month of July, we actually hit 320 for an average. And then you see where we were at with open units. We were at 14, and we were at 15, and then we were at 16, and we're soon going to be at 17 as of October 1st. And then here's what I was talking about with using the beds we have. We've now hit a 90% occupancy rate in July, which we never had that even before COVID. So that just really shows how much improvement we've made in maximizing single rooms that we have that we didn't used to, really trying to not leave a bed empty over too much longer than a few hours if we can be that organized.
Rachel?
Hey, Gene, I have a quick question.
Sure.
I mean, these are pretty steady numbers that matches the number of units. Question I have is, I see admissions, I don't see discharges. Question I have is, are you discharging more people to step down hospitals? I know in the past, you got to, stay at Valleywise for the duration of your inpatient COT, for example. And in recent years, there's a trend of discharging people to a step down that need more time. And of course, where this is going as a family out here, the quality of care at Valleywise is great. The quality of care at some of these step downs that's alleged to be the same level of care is not so great.
And you're right. And in the perfect world, we wouldn't want to do that. We would want to have someone come in for their court-ordered evaluation, have their court hearing, and continue to stay with us until they no longer needed inpatient treatment. But the demand for the COE part of what we do has just continued to be such a focus on the part of many entities, including, your group, is that we're trying to balance that as best we can. We are transferring some folks who need longer stay in a hospital, but now that they're on court-ordered treatment, they can go to a number of other places. With the St. Luke's closure, that's one less option that we have. So I think we'll see that that's going to impact the numbers a bit. Later on, I was asked to address the connections, the UPC pilot. What we're using those beds for is that very population, when they were no longer able to continue doing court-ordered evaluations there, but they had these beds. One of my suggestions to Mercy Care was, why not, at least for the time being, use those as a place for someone who has come in for the COE, gone to court, and now needs a little bit more time. And what we're trying to do is send them back, anybody that started the process there. So at least they're not going to a third place.
Mhm.
And
Right.
that
Makes sense.
seems to have helped the capacity some. I've got some numbers later I'll show you with both the number of petitions filed for COE and the number of petitions filed for COT, and kind of show you what that's done over the last 3 or 4 years.
Okay, Beth has a question, and I do after her, but go ahead, Beth.
Yeah, I just want to clarify, so when, my son was on court treatment, he went through Valleywise, and then we were blessed enough to have the knowledge to get him into a BHRF. But if we didn't have that knowledge, where would he have gone? I just, the numbers, I just want to clarify, where is the step down program and where is that? And where are the bed for those people?
Well, there's two things I think we're talking about. One is step down, which would be BHRF. One is lateral transfer, which is another psychiatric hospital that basically would do the same thing that we would keep doing at Valleywise until they needed step down. So the lateral transfers have been St. Luke's, which I just mentioned, at least we believe out of the picture indefinitely. Aurora Behavioral Health has taken lateral transfers. I think Haven is one. In rare certain circumstances, Phoenix Medical Psychiatric Hospital. Mercy Care says many more of their psychiatric hospitals are supposed to be willing to do that, but haven't been consistent. That part I can't really speak to. So those are the lateral transfers that we would, in the perfect world, not want to have to do very many of. The step downs are basically to the behavioral health residential facilities that you described, possibly some substance abuse kinds of programs, if those are applicable to that individual. Again, we work very closely with the outpatient SMI clinic and Mercy Care to come up with those plans.
But again, the clinical team decides when they're done with their stay and they're stable, based on their clinical team decides, should this person go to a birth, or should this person go to their parents' home? Should this person go back to their apartment? It depends, right? It
Right.
depends.
The clinical team at the clinic, if they've newly assigned or if they've been involved for a period of time. You know,
No,
sometimes folks are newly assigned when they come to us. Many have been in the system for a long period of time. We never
No,
do anything independent of those teams. It's always a
nobody.
collaborative process.
Okay, there was another question. Isn't CBI a step-down facility?
They do operate some step-down facilities. I don't know the names of all of them off the top of my head, but they have some short-term step-down facilities as opposed to a BHRF, which is for a longer period of time. Those short-term ones are supposed to almost be like a stopgap measure between they don't need to be in the hospital anymore, but there's maybe not a appropriate BHRF bed ready for them, and so they can go to those places to stay for a week or two. And CBI does have some of those.
Yeah, Lori, this is Mike Franzak. Back to that clinical team question. The clinical team is involved and is supposed to be involved, particularly if they have the person in care, early on with the discharge team at the hospital. And when someone goes into the hospital, they may not be able to return to that same environment they came from because, well, they're either evicted or they won't take them back because they have to fill their own beds. But the clinical teams, both the hospital team and the outpatient clinical team, work together to decide on the level of placement they need. And Valleywise and their team has been very cooperative in that process.
I'm wondering too, Gene, how many, and I don't know if you have it in your slides. So you have people that are getting quarter evaluation, people that are getting quarter treatment and stabilizing either in your facility or lateral or discharged. How many do you have that need ASH and can't get in and have to stay for a long time? And do these other long-term waiting for ASH patients ever go to any of the transitional lateral hospitals?
Great question. And we just recently did a count of how many we have waiting for ASH, and I want to say it was 9 individuals. Mercy Care actually is the keeper of the official list of pending Maricopa County ASH referrals. But many of those folks were sent to us to manage their care, waiting for the state hospital bed to become available. Some of them came through as a COE, some of them came through as a guardian situation. Very few are able to go elsewhere because I think, quite honestly, most other facilities aren't equipped to take care of someone for that many months, and or they don't want to be doing so. So yeah, it does become a burden on our ability to have the throughput, if you will, for the people that need more COE capacity. But you know, we do several things here that other places don't do. One is the COE process. That's the biggest. One is take care of people that have medical issues, are pregnant, or have serious dementia. And those sometimes, unfortunately, stay a while, and it does impact our ability to do the other, you know.
Eat.
Right.
Oh, I'm probably pretty much, I've been drinking through all day, pretty much.
I think it was just an unmuted mic.
Oh, I'm sorry, I didn't hear what you said, but that's okay.
So essentially, sometimes it takes out almost a whole unit if it's 9 beds, 10 beds, but for a period of time until they can get into
Yeah,
Ashland.
they're spread around, and so it doesn't necessarily impact just one unit, but yeah, there was a question you had about our length of stay, and I've often told people it really is how you measure it. I mean, and statisticians among us know the simplest way hospitals measure length of stay is they take the patient days in a month and divide by the number of admissions, and that's your average length of stay. When we do that, it's 22 days.
Mhm.
But it doesn't tell the whole story because we've got a percentage that are 3 months to 6 months, and we've got a percentage that are 1 to 2 weeks. We have a lot of patients that come in for the court-ordered evaluation, get stabilized, go to the court hearing, and get discharged either that day or the next day. So those are your 7 to 10 day stays. But that sort of divide the patient days by the admissions is 22. And we have seen that go down, which I showed you on that previous slide. We've been as high as 24 or 25 2 or 3 years ago, and have come back down to 22. And a lot of that was COVID driven. We are still placing units on quarantine when we get a COVID positive test. But we have made some significant modifications to our COVID protocol. We now can get it ended at 3 days if it was only one positive patient and no one else tested positive 2 different times. On the 3rd day, we can end it. If that doesn't happen, you get 2 or 3 more, we end it at 7 days. We still have to isolate the positive folks for 10 days until they recover. And that sometimes causes us some challenges, but we do, put COVID positives in rooms with others that are also COVID positive so that we don't have to take up a bunch of rooms unnecessarily. But it's still a challenge. I can tell you that the month of July that I showed you, we had an average of 320 patients. In the month of August, I think it barely reached 300 because we had so much COVID in August as compared to July. Yeah, someone mentioned Dr. Baldwin at Desert Vista. Unfortunately, Dr. Baldwin, Nick Baldwin, has taken a different job within the system, working at Gila River. Still works for DMG, but longer is at our hospital, which we're sad to see him go. He did his residency with us.
Rachel?
Hey, thank you. So Gene, you bring up something that it's kind of implied. So Dr. Baldwin was a hero among us and was our anytime we had someone at Valleywise and we heard it, they got Dr. Baldwin. We knew they were in the best of the best, right? What percent of your providers are new, right? You mentioned that you had to attract and retain and build the workforce. Are you now having a lot more new providers versus the senior staff that we all grew to love?
I wouldn't say a lot. I mean, and again, most of our new inpatient doctors graduated from our residency, so they've been with us for 4 years of residency and learned how to do the work from those more experienced doctors. But we have had a couple at Maryvale, and I want to say one at Desert Vista in the last couple of months that have come from the outside. But Dr. Olson and Dr. Sood, spend significant amounts of time with those new folks and pair them up with some of the more veteran psychiatrists, and I think do the best job we can to have a consistent approach. Yeah. Dr. Olson watches very closely what goes on with the cases, and so I know, I understand, I feel the loss sometimes too when some of these great providers move on, but I think we're doing the best we can to not just throw somebody new into it and hope they figure it out. They're handheld quite a bit.
So, Jean, a question. I know a lot of systems of care now are using nurse practitioners because of cost cutting measures and also because shortages. For people that are that acute and coming in to try to get evaluated and they have there's a lot going on. Do you primarily use psychiatrists? And if you use nurse practitioners, do you use them in a limited capacity or do you use them in a team capacity?
Here's the answer. It's a little complicated. The only psychiatry nurse practitioners we've been using are at the Maryvale facility. At Desert Vista and the Annex, the attending providers are all psychiatrists. We have medical nurse practitioners that do the H&Ps and kind of the medical care. At Maryvale, I'm on a count, there might be 4 psychiatric NPs there. And when we opened that facility 5 years ago, Dr. Olson, I think, felt like she needed to utilize some psych NPs because she just wasn't going to be able to get that many psychiatrists recruited that quickly. The psychiatrists must do the affidavits, though, for the court-ordered evaluation. In Arizona, the court does not accept nurse practitioner testimony for determining someone being placed on court-ordered treatment. But they do have the ability to serve as the attending provider. If Dr. Olson was ever with you again, she could explain kind of how she and her medical directors, there's one at each of the facilities now, determine a new admission if they're going to assign it to a psychiatrist or to a psych NP. But I can tell you the psych NPs that we have a collaborating psychiatrist and the medical director and Dr. Olson. And I haven't seen any real significant, glaring issues with any of them and their practice with us.
Another probably maybe controversial topic is during COVID, and people were having virtual hearings, and now they're back to physical hearings. Do you believe that the virtual hearings were as valid and standard for people going through the court-ordered treatment, court-ordered evaluation? And if so, would you revert back to virtual instead of in your courtroom?
Well, remember the courtrooms, although they're in our facilities, they don't belong to Valleywise Health. They belong to the Superior Court, Mental Health Probate Division. What I can tell you, and I've heard both sides of it, I mean, clearly with COVID, we did a lot of things in this country that were pretty extreme in the first months to year and a half of where, depending on where you live, and from restaurants to airplanes to how we kind of did things. That said, I think to keep this going and to be able to continue to have individuals be evaluated and be placed on court-ordered treatment during the pandemic, I think folks did the best they could, and it continued to happen. It was much slower. Definitely saw a decrease in the amount of folks we were able to get through the system. But once we began to start doing it in person again, I think especially some of the arguments from the individuals who serve as the defense attorneys, public advocates for the patients, they are the ones who primarily felt like not being able to be physically present and to kind of see what's going on and to see the faces of the witness and the face of the commissioner or the judge took away from their ability to participate. And I think it would be hard to argue that completely. So those are the two sides. I think we had to do it, but there's a point in time, and that really is what I understand what led to the ending of the Connections UPC pilot was there wasn't going to be a willingness on the part of the mental health probate court to continue having virtual testimony and participation in hearings. And, you know, I was not in a position to argue that one way or the other.
We do have a question from a iPhone. That's all I know.
Hi, it's Holly Giesel. I just wanted to let everybody know and to compliment Gene, your staff, and of course, Dr. Olson. We are doing from Desert Vista on Friday a virtual sentencing because the individual is hospitalized at Desert Vista. We were able, with the help of staff there, to establish that his competency to enter into a plea. I was able to go out and meet with him, go through the plea, and the staff out there has offered to make sure in talking with him to go through the plea and assure that he understood all the questions that he had indicated he did, and they are doing this today or tomorrow. And the Superior Court granted the motion to do the sentencing from Desert Vista video. I can tell you that there are a lot of, not many hospitals in Phoenix that are as patient focused and as participatory in the forensic process as ASH is. And so it shows what you can do video when you have a reasonable prosecutor and the defense lawyer is willing to do some extra work. But what the staff out there did has just been extraordinary, just extraordinary. And I want everybody to know that. It's deeply appreciated, and the judge was incredibly appreciative of it because it gets the case off of the calendar every month. The prosecutor's office was appreciative of it, and Blaine Gowdow, who's the principal deputy to Rachel Mitchell, sent an email and said, "Thank you very much. This is innovative, and we're happy that it worked out." So it's kudos to Valleywise. It's probably the only hospital.
Holly, let me interject. As the father of that patient, I can attest to everything that Holly just said, especially the responsiveness of the staff at all levels. When I go to see my son, when I talk to staff on the phone, they return phone calls. When I talk to my son on the phone, all of the above. And as I go through this, I ask myself, why can't other hospitals be more like that? I'm not seeing anything that I would consider to be significantly more costly. It seems like it's more a matter of culture. And my compliments to Dr. Olson, Dr. Weinhold, Dr. McKnight, and Dr. Guthrie, and others on the staff.
The social workers, yeah. Leah, I'll have to look up her name. Leah, the social worker followed up twice.
Noelia.
Yeah, Noella. She's followed up twice and called to confirm several things with my office, coordinated the visit. I mean, how many times did the parents on this phone call their team social worker 15 times before you ever get through? I almost thought it was like a typo when it said, "I'm Mike's social worker." I thought, can't be, not possible. No, but
we've had interactions with other hospitals where the doctors won't even do a doc-to-doc conference. They just won't. and they change the medication en masse without even talking to the clinical doctor. I mean, I don't understand why other hospitals can't be this good.
Cloned. I also just want to tell you, Gene, that I was scheduled to go out and sit and have a conference with Mike in one of the interview rooms, and I did that, and I said I'll be there between 5 and 6. I got there late, but the staff at the front door, the security officer and the receptionist said, "Oh, you must be Holly. Welcome. How are you?" The security guy said, "Do you want a water bottle? It was really hot." I got through. They had my badge. I got through. They walked me up, showed me the way. I went upstairs. The nurse met me at the door to the locked unit and said, "Oh, come in." I asked, "May I bring my water bottle?" And she said, "Oh, of course. And if it's not cold, we'll get you another one." I thought I was at Mayo Clinic. I was looking for like the grand piano playing Bach in the background, right? I mean, it was truly, it's remarkable. And I just think we don't appreciate sometimes the quality of the people and their commitment there. So I just wanted to acknowledge that.
Yeah, I believe that Valleywise is an exemplar, a model that we want to see in other places. And I'm just wondering if Gene's considering buying St. Luke's.
I was wondering that too. I was
Amen.
going to ask that. Yes.
We haven't even been able to fill our own Maryville hospital that we bought. The problem with the St. Luke's, as I think we all know, is the building itself is really, I think, beyond its useful life. And the company that ran St. Luke's doesn't even own the buildings anymore. So I don't know who you would even be dealing with. So.
Gene, to kind of piggyback on that topic, have you considered maybe branching out and having some court some court order evaluations at the like CBI or other places, so that you know, you kind of unclog the system, if you will, because I see that that sometimes we run into issues that we petition patients, and then they stay at CBI or other facilities, and then the petitions expire. And I'm absolutely grateful for Dr. Olson and for everything that Valleywise does. It's I'm tremendously grateful for that hospital and your staff. So that was my question, if you're considering, and I don't know the logistics of that, but
So Janina, they ran a pilot study, and it wasn't Valleywise that ran it. Mercy ran it with CBI, but it's the courts that won't allow them to do virtual courtrooms. They'd have to build a courtroom, right, Gene, in their facility, because they won't
That's
allow
what it was
virtual anymore.
coming down to. So we're really all trying to figure out how do we maximize it. Now, I think you all know we've got 2 courtrooms at the Maryville Hospital and one at Desert Vista and one at the Annex. So we have 4 courtrooms within our facilities, and we want to get those to the point where they're at maximum capacity. The Desert Vista one is already by far the busiest because it's the only one there. Maryville has the 2. Yeah, I was going to say the same thing, Dr. Costales. It was
yes, Dr.
BC.
Costello, you're absolutely right.
but we it is. I mean, to accomplish that, if we could reduce our length of stay, I'll just make up a number, from 22 days down to, let's say, 17 days. We drop it by 5 days. I did the math. We could probably get another 100 people in a month just by doing that. Where the connections pilot was doing about 30 to 40 a month. So really, some of it is capacity, some of it is how long people stay. And, we're balancing out back to that first question. Lateral transfers open up more space, but it does impact the quality of care for those individuals. And, it's tough.
Gene,
to do.
what would be your recommendation for how the state of Arizona can regulate or oversee or intimidate or whatever these other hospitals to be more professional? I mean, you're in the belly of the beast. What would you recommend? It's
Well,
ridiculous.
it starts with, I've always started with treating people with friendliness, helpfulness, and respect. It's amazing what people will kind of give you the benefit of the doubt if you treat them nice. We also, though, have invested heavily in our psychiatrists and our social workers. I mean, we have a caseload of 9 or 10 for most of our psychiatrists. That is probably less than half of what the psychiatrist in these other places take care of. So I don't want to say anything against healthcare systems that are in a for-profit type of situation, but that is the most common structure for psychiatric hospitals. And so, yeah, there's a lot of pressure. They don't have as many resources allocated, and they're stretched pretty thin. And so I'm not sure you'd ever, even if you had a perfect social worker and a psychiatrist, that they would be able to be as responsive in that environment.
So Rachel, you've had your hand up for a while, and then after that we had Evelyn.
So 2 quick questions. One's quick. Would you support legislation that would authorize physician assistants to participate in court-ordered evaluation? So that's one. That's just a yes or no question. And then the second question is on that, and you may not be the one to answer, that COE pilot program at Connections at UPC, in any other field of technology or healthcare or whatever, if you have a pilot program, the parameters are identified in advance. That was an investment, that was a program that would have had very clearly defined outcomes from the beginning, before the program even started, to know if it was going to be considered successful or not. How is it that we've heard nothing of those outcomes? We've got no metric for whether or not that was successful. All we have is that the OPAs just decided they didn't like it and said, nope, you can't do that, after that huge, massive investment that was vital to our community. And where do we go from here on that? So that's my second question.
The first one, I'm not sure. Dr. Olson would certainly be the one to represent Valleywise Health. I would say that jumping from not allowing anybody but psychiatrists to allowing physician assistants would be a big jump if you didn't start with the nurse practitioners. But again, I'm not the expert on that. I know that nurse practitioners have more autonomy in Arizona than PAs do. So that may be a hard hurdle if you don't start with the nurse practitioners and then move it on to PAs down the line.
It would be for the second evaluation.
Okay, well, again, Dr. Olson is our expert on that. I could talk a little bit more about the second question. I was involved almost from the beginning. I think there were some initial discussions between Mercy Care and Connections before they brought in Valleywise and the courts. But yeah, as I understood it, and Dr. Costalis, I think, is on here, she might be able to address maybe there at the very beginning. But yeah, it was to deal with the fact that we had more people being petitioned to get a COE than we were able to manage in our Valleywise Health system.
Yeah.
And it did accomplish that. I mean, they, like I said, were able to do 30 to 40 or so a month. That was on top of what we were doing. I can tell you just, and it's only been a couple of months now since their pilot ended, but the process that we've started where we send people back after they've been to court, the total COEs being done has stayed about the same as it was when they were doing them and we were doing. So I think that has allowed the capacity to still stay up there. It is moving people around a lot more, but it's what we were able to do given the rules. Having done this for nearly 20 years here, and sometimes the rules that come through the judicial branch can be a little bit difficult to understand, and I've sometimes learned that sometimes it's better to fight the ones you think you can fight and accept the ones that you think you can't. And given the funding limitations and the lack of willingness to, it's not just building a courtroom as the court people told us all, but you'd have to then staff it, and you'd have to have more attorneys and judges, and that would be on a permanent basis, and the county would have to allocate that funds. So I think the pressure then became back on Valleywise is how quickly can you maximize the use of the resources that are already allocated to you from the judicial. And as I said, 18 months from now would be the maximum that we would be fully there. And I hope it can be sooner.
And Rachel, just to let you know, Connections did present to us, and their slide and presentation are on our site, and all of their numbers, their success. I have I just pulled the slides up, so we have all that information.
Right. My point was we made that huge investment and established on agreed upon outcomes, but yet somehow why did we even bother if we knew the OPA was going to come out and say, well, we don't like virtual and we get the final say?
I don't know. Yeah.
Yeah.
I don't know if the OPA was involved saying if this is successful, can it continue? I don't know. We'd have to ask, but
on top of that, there was changes in the presiding judge of the mental health division and their administrative leaders. And so, yeah, a lot of things I think came together that made it difficult for that to continue.
Yeah,
And I don't
Evelyn?
want anybody to think I wasn't. I mean, we were fine with that happening. It wasn't as if there wasn't enough folks who needed the help to go around. It was just once we learned that it wasn't going to be continued, we didn't want the total numbers to start to be affected. So I think what we did under the circumstances at least prevented a drop in the amount of individuals being evaluated. It just made life a little more complicated. We're paying for it in ambulance transfers.
Okay, Evelyn? I know you've been patient. You're on mute. Evelyn Burton, you have your hand up?
I can't unmute her. Maybe you can.
No, we can't unmute people. They have to unmute themselves. So Janina and then Teresa, and if
So,
Evelyn
quick
finds the
question.
button.
And this might be for Dr. Olson. So I'm a psychiatric nurse practitioner. So if the laws were to change and allow NPs to sign off on COEs evaluations, would you consider a training / residency program or something of that nature to provide adequate training to and more information to the NPs to be successful in that.
Again, yeah, Dr. Olson question, I
I
don't know. You know, we have done a lot of trainings, but it depends on how in-depth and how much time it's gonna take on the part of the psychiatrist.
Mm-hmm.
You know, obviously the ones who worked for us and were doing that get the training, but
Right.
I'm not
So,
sure about, because
right.
we have even provided trainings, Dr. Costales could talk about that,
Okay.
to some of the psychiatrists just to understand how, when they see someone there and how it's going to work in the court system and all that. But it probably is an area for improvement, especially as this gets more complicated in the years to come.
Right. So, that would be fantastic if nurse practitioners would be able to assist with that process. But obviously, they have to have a certain level of competency or training or whatever to make sure that it's done correctly.
So,
So that
yeah. So Teresa?
Yeah, just going back to, what was being said about the pilot program. So I, helped to launch the pilot program at UPC. And it was a huge undertaking, getting into starting to do court-ordered evaluations. We staffed up that unit even more than our other units, kept the caseloads very low. And I think that is another thing that Valleywise does very well, is keeping those caseloads low. That was a very good point that you made, Gene. And we do that here as well. So it had well-defined goals. We tracked data very, very carefully. We met with stakeholders at least monthly, sometimes more often. We were having very good outcomes. We got it up and running very, very quickly, and certainly we were providing another set of 16 beds for court-ordered evaluation. We were disappointed and surprised when it ended as abruptly as it did, and there wasn't a ton of interest in what our outcomes were at the end of the program. It very much, as Gene alluded to, became about funding. As far as the virtual hearings go, I never heard a solid argument from OPA that virtual hearings are actually detrimental to their clients. They have been pressed on it, have not been able to provide any evidence to suggest that virtual hearings are detrimental to their clients' cases in any way. Nonetheless, we did the job that we were supposed to do. We even offered to buy a van and take patients to court if we had to have them in person. But we ended up learning that the program was not going to be funded any longer, and the focus was going to remain on Valleywise, utilizing all of their resources that they have in terms of their courts and the support for their courts that they have. So we had to sunset the program within, I think, a month, quite abruptly.
Thanks for the explanation. I shared some of the results and they did have good, oops, sorry about that. I'm probably making everyone seasick and nauseous with my scrolling. But
Thank you
but
for bringing those up, Lori.
Yeah.
Yeah.
So did the OPA's office have any, I mean, I presume it, were they, I don't know. It's just fascinating to me that something this important, this planned, this constructive and vital to our population could have just been shut down by the OPA's office. Are they the end all be all decision makers?
if you have anybody on the call who can answer that, all I can say is, they were a part of it, the cost of doing the alternative. The one thing I've learned from the OPA role over the years is their job is not to advocate for what's best for the person. Their job is to advocate for what they want. And they see that as their job is to advocate that this person does not need court-ordered treatment. And so they don't want to do something that makes it easier for them to get court-ordered treatment. And if they can use that argument that not having a full hearing where they're physically present in the room could be somehow construed that it makes it easier to just sort of make it an automatic process, people will listen. So
Why didn't they bring that up before we invested millions of dollars in this thing?
yeah, I don't know, because I don't think I was involved at that early stage until we knew that it was going to at least be given a chance.
So Evelyn's question is, can witnesses and parents still participate virtually at the hearing?
You mean the ones that we have in the?
Yes.
They can. I think that again is something that the two attorneys have to agree on and make a decision, and they can make that happen. But I think the preference is going to always be that they come in person.
Okay. I think it's Holly with the iPhone hand up.
Yes, Lori, thank you. Can you hear me?
Yes.
Yeah.
Okay. I can speak a bit to the OPA issue, and Gene is exactly correct. It's important to know that the Office of Public Advocate is appointed in the COE process as the patient's lawyer, but they are not a best interest lawyer. Their job is to get the patient what the patient wants. And that's different than even a private lawyer. When I have a client who says to me that he's Cleopatra and he wants to take British Air tonight to London to go to Cairo, and because whatever, I'm not going to help that patient get somebody to pay for his British Air ticket, right? So it's a very different role that they have, and they are very steadfast in their determination to fight COT. They do not believe that court-ordered treatment, involuntary treatment works, quote unquote, to speak, to put it in shorthand. Now, that's their public presentation, which Gene described exactly. In private, they have more moderate views, but I don't know that I've ever heard an OPA lawyer say, I'm going to support this COT. I'm going to work to make sure that this happens because I see that this patient needs that. They are much more aligned with the voice and choice orientation. So I think that that's really important to understand here. They don't think it's their job to help facilitate court-ordered treatment in any form. They were involved at the beginning and in the design phase of the study, and they were willing to sort of see how it was going to go, but they never said we will accept the results if it shows that it's feasible. They just simply were not going to be obstinate enough and disruptive enough to say we won't participate, we won't attend meetings, we won't be part of the process. And I respect them for that. So I hope maybe that clarifies a little bit what their philosophy as an attorney is as to their responsibility for the client. And in terms of what OPA's job is, they are correct.
And they apparently have veto authority.
No, I don't think that's accurate. I think that's a good line for TV. And if you're asked, I would say, well, they have veto authority and look what it cost us. That's catchy and I like it. But I think that they were very clear in their opposition, throughout to the people who were listening, and their arguments prevailed. This is highly dependent. I don't know if Jim McDougall's on, Josh is on. This is dependent. The person who takes ultimate responsibility for the success or failure is the presiding judge in mental health court. That changed. And I suspect that for whatever reasons, other advocates for video courtrooms and so forth just decided it wasn't, maybe they quit lobbying for it because it just kind of fizzled. And those things happen in public policy, particularly when you're looking at capital expenditures and so forth. So I don't think they vetoed it. I don't think that's accurate. It wasn't sent to them to say, okay, here are the results, thumbs up or thumbs down. So I think it's also important to understand the thing I think we need to be focusing on is a courtroom is no longer today what a courtroom was 3 years ago. And all you need to have a courtroom is a secure room with a lock, somebody that brings in the person, two sides to the room, meaning two tables, and a person who's going to sit as judge and a place to have chairs. It's an average sized dining room. Maybe slightly larger, but it's certainly doesn't have to be a huge space. It can be smaller than a garage, a 2-car garage. And the way to deal with a lot of the public advocates' concerns was to say everybody has to have their camera on at all times. We do that in criminal cases. You can't do a virtual plea or a virtual arraignment if the judge can't see the person and say, state your name and date of birth for the record. So we can solve easily with technology a modern courtroom, and it shouldn't cost millions. I think it's more about the philosophy and not wanting to make it easier. And I said more than I should have, but Josh, you know it well, intimately.
Well, just a couple points. I think that this is one of the most important things in the civil commitment process is having the adequate number of evaluation beds necessary. And the fact that it didn't go through, I think we should do another stakeholders on this very topic. Yep. Because so many things just, Rachel, my response to their veto power is that once they put up a fight, there wasn't the political will necessary to push back on them, because in the same division of the court, the guardian, in the probate division on the guardianship side, I have not been to court in years. I've done trial after trial, evidentiary hearing after evidentiary hearing online. So in the same division of the court, we are taking away people all of their rights, all the rights to make any decision in their life. In the guardianship court, we're doing it. So the OPA arguments never made sense, but there wasn't somebody there to push back and say, hey, no, we're going to stand up and we're going to fight here. I think it's worth a review. I think that we could probably put on a town hall where we had the court come and talk, where we had OPA come and talk, right, and have a discussion, because that pilot was instituted for important reasons that I think have only intensified since it started. So I don't think it's something we should allow just to kind of sunset. So those are my thoughts.
Looks like Acme has a new project.
Yeah. One question, Gene, because I know when we talked, they said an hour, so I don't know about your time. There was one thing, and maybe I missed it, but Did you have a percentage of people that are put on COT after evaluation? Do we have a number? Is that 60%, 20%? Is it going up? Is it going down? Was there a difference between Valleywise and Connections? Any of that
Yeah.
information?
I've got all the statistics from the county, from the court itself, and they're not the easiest things to look at. I mean, so I can tell you the anecdotal answer that I have, which is, we by the time someone gets through the process at one of the screening agencies, Connections, Community Bridges, Recovery Innovations, and then they get to us, and then they get a petition filed for court order treatment. There aren't very many of them that, have now improved such that they no longer are appropriate. So we don't see very many that we, release before the court hearing. But there are still a handful a week. Again, I can probably try to delve into these statistics and get you something and send it back to you. But just for the sake of the discussion, there are some that get dismissed in court, which I think that if there weren't, we would all, I think, be concerned that the process was too, there weren't checks and balances, I should say. So there are some cases where the public advocates make a strong argument that the person would accept voluntary treatment. That means that they don't need a court order. There are some that the witnesses aren't have changed their mind, or they don't want to testify, or the testimony is not strong. So those are the two primary reasons we see that folks don't get a COT that
I don't think so.
we've processed for a COT. But it's not huge numbers. If I had to guess off the top of my head, I would probably say, somewhere around 90% of the people that come in to us for a court-ordered evaluation get placed on court-ordered treatment. Because we all know that the screening agencies are converting to voluntary or finding the person is not in need of court-ordered treatment in percentages upwards of 75, 80%. So they've already screened off the folks who need something else besides a court order. And they come to us after they've been with them, a few days. We move them forward with few exceptions, and then maybe the court in their process find legal reasons that they aren't appropriate.
Okay, any final questions? I mean, I know we've overextended your stay, and I don't know if you have time commitments. Okay,
I
thank
appreciate
you.
the interest.
You were gonna share numbers of COEs versus COTs. Did you have absolute numbers for that?
I do. I can. Why don't I promise to get them to you? Because this county thing, I'll show you one thing that I'm looking at, and I'll show you. This is, some of you may appreciate it, some of you may. But this is the kind of data that we get from the county, from the courts. So there's so many different fields. The top one is petitions for court-ordered evaluation filed. So since January, you can see the number has been generally, with one exception, in the 900s a month. And you can see the last of the months that Connections was doing. That's where I got the numbers, where they were doing between 30 and 40. And then you go down to the petitions for court order treatment filed. So again, this is not, it's 940 to 436. That's not how many came to Valleywise and then how many went to court. We'd have to see, you could see here, there was 458 of those folks did not end up coming. So let me do a little more analysis.
Is this publicly available?
I don't know that it's publicly available. I can tell you the person at the county that compiles it, and then they can tell you whether it's publicly available.
Okay, I'll
That'd
reach
be-
out to you.
Yeah.
Um,
Well, if he's gonna send the information and send us some, he can send the contact in, so we'll have all the information.
Yeah,
We
I
put
can
that in.
send you what I can come up with. I mean, it also shows the total court hearings by courtroom. And that's where I told you that, for example, in July, we did 139 court hearings at the Mesa at Desert Vista. We did 95 at one of the Maryvales, 68 at the other, and 53 at the Annex, for a total of 359 court hearings in the month of July.
Lori, it's Holly Giesel again. I just saw that, I think Janine is still on the call. Is she on the call? I hope so.
Yes.
I want everybody to know that, I had a client who was not doing well. And I won't say 100% certainty. I have 85, 80, 90% certainty that but for Janina's intervention, this guy would be in jail and charged with felony probably. She went to his house. She made a house call after she saw him. She followed up. She stayed on top of it. And once again, I just want to acknowledge her and let everybody know how much she did through COPA to help this young man. And his life would not have been the same, and he wouldn't be where he is today. I only have 30 years doing this, but nothing's 100%, but I'm 85, 90% sure of that. And I just wanted to acknowledge her and thank her.
Thank you. I appreciate
Anita.
it.
Okay, we have one more question from Evelyn before. If you want to go, then you can go and I'll stop the recording. But does Mercy Care pay Valleywise if a commercial insurance ends authorization for a hospital stay? Probably not medically necessary. And does Valleywise does not think the person is ready for discharge or had their hearing? So if their commercial payer says no, we don't agree, what happens?
No, we don't have that happen as much as you would think. We are very adept at dealing with the various payers and getting someone enrolled in another payer source if it's appropriate. But I can tell you that we do have a number of individuals, we review them every week, who have no payer, and we are continuing to treat them until such time that we feel it's safe to step them down. So it is one of the things, somebody asked earlier if we're a nonprofit. Technically, we're not a nonprofit. We are a government entity. We are the special healthcare district. We do get some property tax and other public funding in the form of disproportionate share federal dollars. And so we take that very seriously and don't make a decision to discharge someone without a payer, without careful consideration to the alternatives. So we maximize the payment we get, but if we have none and we feel like we've taken on this person, we're going to make sure that they have a safe discharge.
Thank you. Evelyn, I think that answered your question. I'll check the chat again real quickly.
Yeah, but I think I think she alluded to, does any payer or including Mercy Care step in and pick up the difference? And that answer is.
I have a question related, Gene. Does Valleywise bill guardians for patients who are committed there on court-ordered treatment?
That's a good question. I'm not sure I know the answer. I mean, we bill individuals if their payer source has either exhausted or has denied the stay. So I don't know why we wouldn't bill a guardian if they are responsible for the financial aspects of managing that individual's life.
Okay. Thank you. I had never heard of this before, but I spoke with a person today who is receiving the son is in the forensic hospital at Ash, and Ash is sending her bills, thousands of dollars for the son's care at the forensic hospital. I've never heard it before, but I don't think she is going to pay them, but it's just, I don't know. I thought I'd ask you. Thank you. It's certainly going to be a disincentive for people to be a guardian if hospitals can start billing them.
Yeah, I don't know that I've ever heard us billing the guardian. I mean, I would think we might bill the individual, and if they're like the fiduciary over their finances, that they would have to arrange for that to be paid.
Yeah, I think that from the times, what I've seen is that if a patient isn't indigent and they get services, then those agencies can bill that person. Just because they're a guardian, like they don't have to pay it, but they do have to pay it out of the ward's money if they truly have the money to pay it and they're not indigent.
But this is the forensic hospital. You don't get a bill when they send you to prison.
I don't know. Yeah, I don't know.
Hopefully
But it's not prison though, right? I don't know. I do know that they can bill people for things that they get reimbursement. I've just seen situations where someone's getting a check after the hospital already paid for something, and then when the person gets the check, they're supposed to pay the hospital back.
Yeah, this is per diem. This is like per diem stuff.
Yeah.
I don't know. I have to get to the bottom of it, but I thought that I would ask since because Valleywise is a government facility. I thought I'd ask. Thank you very much.
Yeah. We have Mike Sheldon speaking soon and giving a stakeholders talk, so we can ask him.
No, I don't ask him questions in public because we're in litigation. That would not be proper.
Okay. I mean, we could always submit general questions. Is it the practice of a hospital to ask to bill patients that aren't indigent that are in their care? I mean, it's kind of a generic question. Okay. Anything else? Okay. So in the chat, someone said that only time a guardian of an adult would get a bill is because the mail to the address is listed. Otherwise, only the adult patient is liable for their bills.
Yeah, and that was me. Hi, I'm Debbie. As far as billing goes, it's going to be based on, who the payer source is. That's either going to be insurance or private pay. The mistake that parents do is they'll say, I'll do anything. I'll pay for it if you help and save my adult now. When in reality, the debt is by the adult, not the parent or the guardian. So that is how I understand it to be.
I'm just not aware of any statutory authority that permits Ash to bill a forensic or a civil patient or their guardian when they're court ordered by the court to go there.
Right.
I don't know the authority, and I haven't seen the bill. I just thought I'd ask because of the, guardian call.
Yeah.
I'm going to send her to Josh.
Okay, well, thank you, Jean. I think we'll now transition. You're welcome to stay on, but the second part, different parents and family members may ask for help or just some thoughts if they're having a struggle with someone in the behavioral health system. And people on the call that have varying amounts of expertise in different areas can jump in and help. But that portion we do not record. So I'll stop the recording.